everybody. I'm Dr. Amy Brower from the American College of Medical Genetics and Genomics. Welcome to the December Newborn Screening National Pilot Monthly webinar. This month, we're excited to welcome the NICHD IDIQ Newborn Screening Pilot Studies teams. We have a team from New York and a team from Emory who are going to update us on their efforts. This is the last time in this forum that we'll be hearing from the IDIQ pilot teams. So we're excited to welcome them and look forward to having an active discussion. If anybody has any questions following the IDIQ reports, we can turn it over to see if there's anybody else on the call who's conducting a pilot who would like to share with the rest of the community. So with that, we'll get started and hear from the New York team. I saw Dr. Kajana's on. I know Dr. Orsini messaged that he wouldn't be able to attend today, but that he would provide some additional updates via email that we'll share after the call. So Michelle, did you want to give us an update on what you guys have been up to?
Sure, thanks, and good morning, afternoon, or evening to everybody. I was going to give you a brief update on our cytomegalovirus pilot that we began screening on October 2nd, and that was 2023 of this year. I see that I think Norma is on also from our lab, so she can add any info or correct me if I misspeak. We implemented the screening on a Monday, October 2nd, so we're really screening babies born September 29th and 30th. So we started for a period of 1 year, and so we will screen through September 30th of 2024. We implemented this pilot as a universal screen, so all specimens received are coming in, all samples are screened, and we're giving parents the option to opt out of actually having the results recorded. It was not practical for us to screen the number of infants that we decided that we should screen in a consented fashion because of the way that it would be very difficult for us to parse that out and actually have the hospitals give consent. So we designed a brochure that explained that this was a new test. It was being done for a period of 1 year for parents. It has a tear out page that the parent can fill out if they want to opt out of the result. And then they can send that in a couple different ways. So they can send the form in, give it to the nursery staff, and have them submit it with the baby's newborn screening card. They can use a QR code on the front of the brochure and brings them to a portal on our website where they can enter the baby's lab ID and some information and click the button to opt out at that point. They could email our program, call our program, various different ways. We wanted to make sure we had accessibility to, everyone in the state had this option. We gave a webinar, Sarah Bradley and Follow Up gave a webinar and had 185, I think, attendees talking about the screen and what the obligations were for the hospitals. We also had that brochure translated into 17 languages besides English. So that was also part of the kind of education. We sent all these brochures out to the birth hospitals, and then we also have them on our website for order for some of the more rare languages, so that hospitals could get copies of languages that they had clients speak within their hospital or their region. I'll talk a little bit more about the numbers with the opt-out in a minute. So we screened, as of about the third week in November, 30,661 babies. Of those, we had 91 referrals. So if you look at the overall referral rate in New York, it is about 1 in 400, 1 in 450. This is in line with the Minnesota numbers and also with the Canada, the numbers from Ontario as well. It's kind of interest that of those referrals, 24 babies are NICU, were in NICU, which is about 26% of infants that were referred, and that is compared to about 10% when you look across New York State of the population of NICU infants. So two plus times the number were in NICU who screened positive for CMV. Of those, 2 were symptomatic. One was found to have jaundice and microcephaly. The other one had microcephaly and hepatosplenomegaly. We have confirmation that 13 babies were confirmed with CMV by urine PCR as an asymptomatic otherwise. When we began this, we had the situation, of course, where when you're screening all the samples coming in, there's repeat specimens in there. And so we had some babies who had a previous screen. And then when we got the repeat, it was positive. And so for those, we created a special health concern kind of a form to get permission from the provider and the parents to go back to the initial specimen and test that to see if it was positive or not. And a couple of those are probably acquired infections. This is particularly happens with NICU babies because they tend to have, by protocol, they have multiple specimens collected. And we've had some situations where the first 1 or 2 are negative and then the subsequent one is positive. And we presume that they're NICU acquired infection when depending on the age of the baby at the time. One baby who we presume was an acquired infection passed away, and then one baby's parents refused any follow-up. I saw a quick question about specimens. We used 2 3-millimeter punches to do that. Oh, somebody might have answered it. Okay, Norma answered it, so there you go. So when we talked to DLA about the possibility of doing this as a 1-year pilot, our regulation in our state had changed from having to go through an entire regulatory review to being able to post conditions on our website and screen for them. My phone's ringing. So we got advice from them, like I said, this whole opt-out thing, that we could screen all of the samples, but that we had to do education and make sure that the parents of birth hospitals, birth attendants knew that this was ongoing and that they could opt out. And we ran by them the fact that we couldn't opt out of, parse out, set up that whole thing for 1 year to be able to parse out babies who wanted to screen or didn't want the screen, whose parents did or didn't want the screen. And so we came up with this brochure approach to allow them basically to remove the result from the baby's record. We put a note on the mailer that says that the baby's parents opted out of receiving these results, so that we have that recorded on the report if the baby does show up later on with symptoms related to CMV. So up to the time that we looked at this data, we had 53 opt-outs out of the 30,661 infants, and about a third, almost a third of them, 32% were home births. So that was kind of interesting because that the birth attendants, have to have the information to make sure that they educate the moms about the CMV screening. So we're happy that that was happening. We also said, see the number here. There was a limit. There's actually a kind of a limited number of hospitals that we've gotten opt-outs from. So we know at least those are doing the education and giving the parents the brochures. So we had 15 different birth hospitals that sent in opt-outs for babies born there. We set up this whole online portal, like I mentioned, with the QR code, where a mom could literally be in the hospital, hit the QR code on the brochure, it takes you to the website, and you can opt out right there. And we have gotten 10 of those. So about 20% overall use the portal. And it's kind of interesting because that's kind of what's happening. We are getting some of those refusals for the results before the sample even arrives. So the ones coming in the portal really are in real time. And 33% were via the paper form, which we created. And people who we have a somewhat of a significant Amish population, and a lot of them don't have access to electronics. And so the paper option is good for those families. So that's kind of where we are right now. It's kind of interesting. We have had some cases of twins where one baby was CMV positive and one wasn't. And I think we had one twin pair where both babies were affected. And we're aware of one false negative where a baby was symptomatic, and the specimen that we tested was negative. And we know that the sensitivity on dried blood spots is lower than we typically have in newborn screening. So it'll be interesting to see how many of those we detect. We're working with the EDDI program to sort of get a comparison between babies who fail their hearing screening. In New York, there's already a law that says that babies who fail hearing screening have to have a urine PCR for CMV. And so we have that data from the EDDI group. And then we're going to compare what the babies we detect and how many do and don't have hearing loss. So that should be an interesting comparison as well. And I think I hit all the highlights. So any questions?
Go ahead, Dr. Friedenberg.
Muting myself, just unmuting myself. Michelle, do you have you have any information on treatment decisions with the asymptomatic babies who have tested positive? It's really on the follow-up and it may be early. Or
Right.
do you get that information, and do you have anything to share about that?
So on the kind of along those lines, what I forgot to mention, we also have a third task order and it's not to our program, it's actually to our providers. So this is my sort of shout out to them. We've had a group of 11 providers across the state who are very engaged and very cooperative. They get on calls every month, have really worked hard to help us implement this screening. And they have set up a registry so that all babies who screen positive in New York and have confirmed CMV will be offered entry into the registry for follow-up. And so the way we have it set up is the babies will receive a minimum of 2 years of follow-up and a maximum of 3 at least to start. So a baby who is identified, who was identified in mid-October will have follow-up through 2026 as it stands. And then the last baby in September of 24 will have 2 years of follow-up. So the third task order goes through 2026. And then there's hopefully going to be a mechanism to actually apply for a grant to sustain that. And that's just getting started. And part of that is to see kind of what the follow-up on these babies are. So they're being monitored. We have a diagnosis form, just like we have for regular, newborn screening, that has the various sort of checkoffs for different symptoms. And so that's for our purposes. And then the providers are working together and they talk about cases and what to do in these situations. But it's in their kind of in their wheelhouse as to how they're going to follow these kids. They do the basics, like they do the head circumference, they look at the hearing screen and that sort of thing to start. No baby who's asymptomatic is being treated that I'm aware of. I think, Norma, you can correct me. I think both babies who are symptomatic are being treated, correct?
We're aware that one of them is on antivirals. He's on vanganciclovir. We're not aware of the other one being on treatment.
Okay, so one of the two.
That information will come in the future.
Is this task order, Michelle, through pediatricians? The registry, is that
It's through the specialty care centers that are involved in this project with us in New York. The leads are at Stony Brook, Dr. Sharon Nachman and Dr. Andrew Handel. And they're, it's awarded to us, but we're subcontracting through them because they're dealing with the patient contact. So it's not within the, and they have, Dr. Nachman is very involved in HIV, going back to the early days, pediatric HIV. And so she's worked with a data warehouse that is set up to do the HIV surveillance. And now they're just kind of adding in the CMV to that, using that same sort of platform.
Gotcha. That's exciting. So that's kind of like a new thing that parents are doing, like it's outside of their regular pediatric visits.
It's, yeah, part of it is, I mean, they come back at certain set time frames and see the pediatric infectious disease specialist, just like our other conditions. And then they also work with the pediatrician. So I think they're going to try and get some of the information, some of the basic information from the pediatricians as well.
Do you know, Michelle, is this similar to what Minnesota is doing for long-term follow-up, or is anybody, or follow-up, I should say, is there anybody from Minnesota on the call or other states that are doing CMV? Just wondering if you guys are I mean, it's a great model, sort of thinking about, what are these cases going to need over the long term? And it's awesome that you have 3 years to do that follow-up. That's going to be really great.
Yeah, I don't know if anyone from Minnesota or Canada are on. This was, essentially was developed with the input from the clinical providers. So Dr. Schleiss is on our advisory committee, as is Sandra Rosendahl. So, and we had a presentation at our last advisory committee meeting on, from Dr. Handel on, basically it's just getting off the ground now. They started in early November trying to begin recruitment. So it's pretty early stages.
Does anybody else have any questions for Dr. Kajana or her team? Great. Thanks, Michelle, for that great update. We really appreciate it.
Sure.
Anything else related to IDIQ that you want to talk about?
It's been quite a project. It's a lot of infrastructure building in the beginning to get these set up. But NICHD has worked with us. We've had to meet various metrics to get started. We had some delays on our side within the health department. And we managed to, when you sit down and think about everything you need to do to start a screen for one disorder for a period of 1 year, that's brand new, kind of a new set of providers. We had to move some mountains to do that. So thanks to our staff, to NICHD as well, and to the providers who've really helped us out with this and are really engaged. It's been really rewarding to see it all actually start.
Yeah, it's great to hear about your work with your EDDI program too. Had you already been sort of working, or is that sort of also created some new connections?
Yeah, I mean, we sort of knew each other, but we haven't really had the opportunity to really work together. One of the past, she was an audiologist who worked at New York and was retired, but I had worked with her for several years, and she had an interest in obviously CMV because of the hearing loss. And she's also on an advisory committee, even though she's retired now. And so she's really been a good, connection for us to find people in the EDDI program to work with. And so there's been a big effort within the state health department, I think, to coordinate and draw these connections. And so it's good that we're able to do it with this project.
That's awesome. One final question. Who does your urine PCR for CMV? Is that also within your program?
No, no, that'd be a whole new program. They send out, so they send out to a diagnostic lab.
Gotcha. Okay.
We don't dictate who they go to per se. They have to use a New York State approved lab, but they can send it where they typically do.
Well, I want to take a minute because it's awesome to have you on, Dr. Kajana, because when we started these calls in 2010, you led them for us for many years. So this whole, monthly newborn screening, sharing about pilots began with the SCID effort that you led in 2010. So we just really want to say thank you for over a decade of your team really reporting groundbreaking results and sort of these infrastructure pieces that are so critical to advancing newborn screening. So we just want to say thank you very much for all your time.
Thank you. Thanks. It's been interesting, right? 13-year ride. So
you haven't aged a bit. You look exactly the same.
Thank you. Okay, time to move on.
Thank you. Okay, now we'll move on to our next favorite IDIQ site. So I saw Angela's on. So Angela, you're probably going to lead the charge for your group today. And so I'll just turn it over to you and I'll take notes.
Well, thanks. Michelle presented a hard act to follow because I don't have anything nearly as exciting to talk about, but that's okay. So we have sort of two pilot projects going on. The one with NICHD is our expanded homocystinuria project, and then there's a state, sponsored funded project for Krabbe screening. So for the homocystinuria project, just so everybody is on the same page, we're still conducting our same amino acid panel, but we've set a low cutoff as well for the methionine so that we can see both homocysteinurias, but also look for remethylation disorders. And then all the samples that flag high or low for methionine, as well as all of our samples that flag on the acylcarnitines for the C3 and C3 over C2, all of those samples are being evaluated, and either if they're low risk, like NICU kids on TPN, or if they flag low risk on the CLEAR tool for the C3 disorders, we just recommend repeat screens. But anything that's medium or high risk, or not NICU kiddos, things like that, we send spots over to Mayo for second tier testing, where they're looking at MMA, MCA, and homocysteine. So that's kind of what we're doing at that level for the project. We've been doing this since April 10th. There are no exclusions. All the samples are being tested, just because it's, there's nothing new here except the second tier testing. And so far, we have not detected any cases of homocystinuria or remethylation disorder. Where we do see some impact is where I could see some real benefit is reducing diagnostic testing for our kiddos who are getting C3 and the C3 over C2 results. So, or at least in terms of the biggest impact. It's a 2-year project, so I'm really hopeful that we'll get a homocystinuria case. And we're going to look at ways also to see if we could change our methionine cutoffs a little bit to send more samples for second tier testing to maybe help improve our detection for homocystinuria. So we still have to look at that data and see if that's feasible and in the budget and all that sort of thing, but and not too impactful in the community as well. So we're going to look at that. That's our big plan for that. I can jump ahead to Krabbe really quick because that one's pretty easy. We look at enzyme, and then they are sent, anything that has low enzyme is sent off for second tier testing at Mayo for cycosine. We have no changes. We still, since we started that project, we've still just had the one positive kiddo who turned out to have infantile onset Krabbe disease, and that's the only positive screen that we've had so far. And that's been a while, so no changes there. And that's really kind of all we have going on. We're just sort of plugging away with no exciting results. Knock on wood, it's the holidays. That's when kids like to be exciting, so I'm hoping they won't be. But happy to answer any questions.
Does anybody have any questions for Angela?
So Krabbe, I don't know. I can't remember what our start date was, but I think we're about 2 years into the project.
So Angela, so you're using the CLEAR tool for homocystinuria panel. Is that something new that Mayo is doing or built for you, or are other states also doing something a little similar, or does Mayo already do that also? Or can you remind us of what's going on with this expanded homocystinuria? We know that the HCU of America presented to the advisory committee a few times, and this sort of led to this IDIQ pilot. So can you remind us nationally what people are doing, if you know?
Yeah, well, so I don't know what a lot of other programs are doing in terms of the tools that we use over at Mayo. So there are a couple things that we're doing. One is using the CLEAR tools to help evaluate the newborn screen results. So we had already, prior to this pilot project, been using that tool actively to evaluate our C3 and C3 over C2 results. Because we do get a lot of those, a lot of kids who really just have nutritional B12 deficiency, and that is a whole different project I want to work on. But they, so we do look at those. It kind of divides it into risk categories. So anything that falls into the lowest risk category, we just recommend repeating screens to make sure those kiddos are okay. But everything else we do, something else on. We are currently gathering data in the tools for homocystinuria. We hadn't really been using it. It hadn't been particularly helpful in our follow-up. So we're not using it currently in our algorithm per se, but we are collecting data on that to see if it's helpful to us, or if we can get some diagnosed cases, help contribute all that data and maybe improve that tool. We also had, Trisha was generous enough to help us create a remethylation disorders tool. So we have that as well. And same scenario, we're just collecting data on it. We're not using it to guide our decision making per se, but we're collecting all that data so that we can evaluate it. And then the second tier test is just a dry blood spot that is punched from the same newborn screening card for the methyl citrate, methylmalonic acid, and total homocysteine on that. Did that answer your question, Amy? I'm sorry.
Yeah, no, that did. I was just kind of curious because I know CDC was also working on sort of a different approach.
Mhm.
So just wondering how that ties into this, or if it does, or
Yeah, we hadn't really worked with them much on this. We've mostly worked with, the folks over at Mayo on it so far. I'm really hopeful that we can contribute data in a way, and like I said, maybe find a case or two, which would be great, so that we could throw that back into the CLEAR tool. At the onset of this project, like before we even started the screening part, our goal had been to reach out, and some folks on this call may have even heard from me. We were trying to reach out to states that save dried blood spots so that we could see if we could run dried blood spots from diagnosed folks on the Neobase 2 kit, which is what our lab uses now. I hope I'm saying all that right. And to make a long story short, that just wasn't a very successful endeavor. The homocystinuria is so rare that it was challenging. So we just didn't get very far in that because we were trying to beef up the CLEAR tool results as well with that. But
yeah,
that's okay. Moving on.
yeah, thank you. Any questions for Angela? So Angela, I'll also give you a big shout out and thank you so much for reporting on these monthly calls. I know Emory has been a leader in the IDIQ since they very first started. So you guys have a lot of pilots, a lot of babies, a lot of screens under your belt. So thank you so much for sharing your sort of emerging wisdom on these cases. Going forward, I know we've all really enjoyed it every month to get your take on what's going on in your neck of the world.
Well, thanks. We're always happy to play along.
Great. So now I'm going to move on. I'm going to stop sharing my screen so my colleague Jekka can take over. She's going to lead the call for the next 30 minutes and share some important updates on MBS TRN and give you a preview of our calls in January and February. Thanks, Jekka.
There we go. Sorry about that. Thanks, Amy. So as you know, we have the tool called the Longitudinal Follow-Up Resource, or LPDR. And even though we are in the process of going through our contract and tidying things up, one of the things that we have learned is that there's a lot of good resources that we want to make sure are passed on to the newborn screening community. And so with this tool, for the studies that we have, there are so far 103 CDE sets for different disorders, and all of them have elements with follow-up where follow-up data can be gathered. So in total, there's about 17 studies that are available. And within that, there's about, there's 3 or 4 studies that have lots of cohorts. And so there's lots of common data elements that can be utilized for secondary use. So with what we're doing is, in order to make sure that there's no PHI, we've just been going through and cleaning the data. So this is an example. This is Cure SMA, and it's kind of small there, I think, but basically we're removing anything that is related to the institution or the PIs or any information like, clinic names, things like that, where patients, may be going. In this way, whoever uses these CDEs can plug in their own information, but this is sort of a template to be used for them. Along with the CDEs, we are also providing PDFs of the CRFs or the case report forms. These obviously are PDFs, and so I think now with electronic records, this may not be something that is usable, I don't know, in terms of out on the field at the clinics, but regardless, these are also going to be linked within the LPDR tool so that if needed, someone could print it out if they wanted to. And all these resources will be available until March 25, which is officially the last day of when we have to close out the NBSTRN. However, the website, yeah, until then is when they will be available. Let me see, I think there's are you guys able to see my my slides? Just want to make sure.
Yes, but we're seeing the presenter view.
Oh, I'm so sorry. Okay, is this better?
Yes, thank you.
Okay. Okay, thanks. Sorry about that. So that's those are the pieces in terms
Now we're seeing a different screen though, not your slide set.
Okay. Let me stop sharing and then redo this. Okay. Are you seeing the right screen now? Hello?
It's just not in presenter mode. It's not in presentation mode.
Okay, let me see.
Yeah,
Now
that's
it
big now.
is.
Mhm.
So you can see the right screen now? I'm so sorry
Explore
about that.
explore
Yes.
the LPDR
Yeah,
data tool.
okay, good. Yeah. All right. So let's see, I could go back. So basically these are the slides that I was discussing earlier. But basically the LPDR, as you know, hosts a lot of different studies and cohorts, and there's data that could be asked for, de-identified data that could be utilized. And so, you could share this with your colleagues and let them know that we have this tool and these resources. Are there any questions on the LPDR or the CDEs? Okay, so moving along, you are invited to contribute to the special issue in the International Journal of Neonatal Screening. The deadline for that is January 31st. And of course, we encourage early submission. There's a website and there's also a QR code where you could go directly to the site. The guest editors are Dr. Amy Brower and Dr. Keith Chan from NBSTRN and ACMG. And the focus of the theme of the special issue is in general, the long-term follow-up. So if you go through each of these bullets, there's basically discussing newborn screening research and also what is going on in terms of follow-up, what happens after that early identification intervention. Also looking at genomics that enable screening, diagnosis, and treatment throughout the lifespan, and also any innovative efforts from communities who are helping to chart the course. And obviously on this call, it's the presenters that presented on the cases in New York and Emory. Those are examples of innovation from communities. So we really appreciate that. And We do have calls coming up, so thank you so much for participating in this call. And we will continue to host monthly webinars until February 2024. And we welcome any suggestions for topics and speakers. The ACMG and NICHD teams welcome your ideas and feedback during this change. So some future topics and presenters for January 4th, 2 p.m. we have phenylketonuria, Carrie Harding, the professor of molecular and medical genetics at Oregon Health and Science University. In February, we have an update on NBS pilot efforts from Nikki Armstrong, who is with Parent Project Muscular Dystrophy, and I believe she's on the call as well, and Holly P., who is from RTI International, and Richard Parad, Dr. Parad, who is at the Brigham and Women's Hospital. And with that, just want to say thank you for joining us. And we look forward to seeing you at our next call. Are there any last thoughts, Amy or Jennifer?
No, thank you so much, Jacka, and have a wonderful holiday, everybody. We'll see you in the new year.